Hello everyone, and welcome to Your Health, Your Choice. I am Dr. Roopnarine, and we are coming to you live from our studios at ACTN. On tonight's program, we're going to continue our discussion on orthopedics, more specifically, shoulder pain. Back in studio with us tonight is Dr. Trevor Seepaul. Dr. Seepaul is a consultant orthopedic surgeon at the San Fernando General Hospital. Dr. Seepaul is also attached to the Gulfview Medical Center in Laramie. As usual tonight, our numbers should come up at the bottom of your screens, and we will do our very best to address each and every one of your orthopedic questions during the program. So guys, let's get the show going. Let's talk about orthopedics, and let's say welcome back to Dr. Trevor Seepaul. Doc, welcome back to the program, Your Health, Your Choice. Nice to have you back again.
Thank you very much for having me, you and your viewing audience. I'm grateful for allowing me to come again.
Thank you. So Trevor, let's just, to kick it off, last week we discussed orthopedics, we discussed knee pain, and we had a great feedback, a lot of feedback from the audience. People enjoyed the program. So we said, look, let's push on this week. So we're going to talk a little bit more about orthopedics, but let's focus on the shoulder, because shoulder pain is a quite common presentation as well in general practice and into the hospitals and into yourself. And perhaps later on in the program, in the final segment, if we still have time in between answering the viewers' questions, if we could discuss osteoporosis, because osteoporosis is a condition that I think the society needs to discuss a little bit more, and the treatment and prevention of osteoporosis kind of reduces injuries in a larger scale. So Trevor, if you could just start off, if you could just give us a little outline of perhaps the anatomy of the shoulder, if you could describe it to our viewers, and if you could tell us what are the common reasons that people come into your office with shoulder pain.
Well, thank you very much again, and it's a pleasure to be here.
Yeah.
So, the shoulder joint, as you said yourself, the knee is very important and very common, but the shoulder is probably the next most common joint that we deal with.
Right.
Perhaps you could pull up slide 3 as we're talking along. Many of us are familiar with joints, especially if you're a mechanic. You'll be familiar with a ball and socket joint that you have in a car.
Yeah.
And then you can also see a picture of a Lego joint there. Those of you who've had some amount of a Lego set or played with Lego when you were smaller, and you have this thing that swivels in the joint, and it's well contained. The hip joint in the human beings is similar. It sits very well within a cavity, and it's a sort of ball and socket.
Right.
However, slide 4 please. The shoulder is a bit different.
Yeah.
The shoulder is not a ball and socket, and it has its own unique problems. And it's really a flat joint, so this ball sort of sits there. And slide 4 coming up.
Yeah, Josh, if you could pull up slide 4 there first, right?
Wonderful. So the joint it sits there with the ball on a flat surface, and the only thing that keeps it in is two things really. One, it's a sort of suction cup that sucks it in, like that suction cup that we place on our fridge or on our mirror to hold things up. And it's also a bit like a puppet on a string, because a shoulder has to do so many different things.
Yes.
There are many tendons, ligaments, and it's almost as if strings are guiding the way in which the shoulder moves, depending on how they push and pull.
Right.
And well, perhaps for those of you who are Mission Impossible fans, you can see a picture there at the bottom.
Kind of small.
It's kind of small, yeah. But that's one of the suction cup episode. I can't remember which one it was, but they are holding on to the side of the Burj Khalifa.
Right. Right.
So, but the shoulder is very versatile,
Yeah.
but because of these facts, it's very unstable.
It's an unstable joint.
It's an unstable joint.
Right.
You mentioned or asked about different disorders.
Before we get to disorder, what are the bones that make up the shoulder joint? If you could, because you showed the viewers the ball, well, the semi-ball and the area there. If you could just tell them what are the bones of the shoulder joint exactly?
Sure. So about 4 bones really. We have your arm. We call this the humerus. All right, and that gives you the ball at the top. Many of us are familiar with our collarbone or clavicle.
Yeah.
So we have that there.
Yeah.
And then we have our shoulder blade, which we call our scapula.
Right.
And it is these 3 things that sort of join across and come across.
Yeah.
And it creates a bony tunnel over the top here. So we only feel bone when we touch the top of our shoulder.
Right.
But under this bone, under what we call the acromion, is where all the mechanics pass that allow us to move freely and allow the shoulder to do all the things that it does.
Right. All right, so yeah, if you could just, sorry, before I interrupted, you were going to tell us what the different reasons people come in with pain to you in the clinic.
So it varies through the age groups like anything else, but in the youngsters and those who are very active, especially in sport or even climbing trees, we see shoulder dislocations.
Okay.
So that's a big part of what we deal with.
Right.
In addition to that, when we move along through the ages, we see what we call a bursitis or tendonitis,
Yeah.
or tears in that mechanism that moves the shoulder.
Yeah.
In that light, we also see the frozen shoulder as well.
Yeah.
And we'll talk a little bit about that.
Yeah.
And then there's something called the AC joint, and that's really the joint between where the collarbone comes across and joins on to the rest of the shoulder.
Right.
So these are really the main things that we see in our practice as orthopedic surgeons dealing with shoulders.
So if I could just structure it, Trevor, in the older people, in the over 50s, right? Let's say the over 50s, what would be the main one there that they would come in with most commonly?
So the over 50s would be a spectrum really of the bursitis, tendonitis, tears and frozen shoulders.
Right.
We could look at that. Let's see slide number 7. So what is a bursitis really? Well, underneath where all these tendons pass, there's a spongy little cushion really. And depending what we're doing, let's say we're doing a lot of soaring activities or any sort of turning a pot all day, you know, we might actually inflame the bursa by doing these repetitive activities.
All right, so this could affect any age group?
Any age group, but a little bit on the sort of middle to older age groups.
Right.
Sometimes something as simple as a lot of my patients, you know, will travel abroad to see friends and family, and they will say that when they pull their suitcase off the conveyor, they experience a sharp pain.
Right.
And that sometimes is the bursa being pinched.
Okay.
And the start of a bursitis.
Right.
And depending if it gets pinched a bit harder, you get what we call a tendonitis, and that's an inflammation of that same mechanism that's going to move the shoulder.
Right.
And then unfortunately, sometimes you can actually strain it so badly that you can tear that mechanism and get a tear.
Okay.
And really, any of these 3 conditions, if the shoulder decides to not settle and it decides to misbehave and it starts to swell up and become uncomfortable, any of these can actually lead to what we call a frozen shoulder, which is when you just can't seem to move your shoulder around.
All right. So, I mean, classically in general practice, you know, the patient, they'll say, well, doc, I could get the hand up to about here, and then to move it higher than that, I can't do it. They'll have difficulty like combing the hair, they'll have difficulty doing like buttoning the shirts because the shoulder is very painful. Is that the classical presentation of a frozen shoulder or bursitis? Or?
The pretty much for the frozen shoulder, and our population, as we talked about last week, our population is a tolerant sort of population, and you will often only see them at the point when they really can't seem to do anything, and the shoulder is nearly frozen or fixed near the side of their body, and they, as you said, you can't seem to get it anywhere near shoulder height level.
So before you continue on to the other causes, right? So Trevor, let's say our patients at home, they have an extreme pain in the shoulder. All right, let's try to relate it back to the people at our guests at home, and they get an extreme pain in the shoulder, and they come in to see you. What do you do for them?
So once you come in to see me, I mean, as always, we have a bit of a chat.
Or even before they come in to see you, what should they do to help themselves?
Simple things to start with.
Let's give them some advice, some real practical advice.
If you're having a pain in your shoulder, if you feel you have this bursitis or tendonitis because you overuse the shoulder a little bit, the simplest thing is, one, rest it a little bit. That doesn't mean just keep it in a sling, because then it actually starts to seize up.
Right.
But avoid the activities that you've been doing, whether you've been cooking a lot or laboring a lot, whatever the case may be. Ice compresses can be useful, and simple medications like Aleve, ibuprofen that you could get off the shelf, and there are other what we call NSAIDs or anti-inflammatory medications.
Right. So there's ice, anti-inflammatories.
And rest it just a little bit and see how things go.
All right. So in Trinidad, we have this kind of culture where people, once they get like a pain in a shoulder or a joint or a muscle, they go to get it rubbed.
Right.
I assume that massaged. Or what's your take on that?
Well, I would tell you that when I first started this business, I wasn't too keen on the rubbing, but after talking to patients time after time,
But it's more like massage. Pulling.
Yes. And, some patients are actually helped. Now, I really don't know the science behind it.
All right.
And I don't know exactly how to rub or massage in order to fix things.
All right.
But I'm not going to speak ill of some of our chiropractic colleagues who seem to have things under control.
I mean, it might not be a chiropractor. It might be somebody else who might be doing it. I mean,
yes, and it seems to work. It seems to work. But I think if there's any doubt, see a doctor first.
Yeah.
And get some advice in terms of what the problem is.
All right. So they come in with you. They take some at-home medication, which we all have. We all have ice pack at home. We could all rest our shoulders as best as we can. We could all take some painkillers and stuff. So they come into you now and they say, Dr. Trevor, my shoulder is still killing me. Help me. What do you do?
So as always, we have a little bit of a chat and an examination, but the key behind it really would be to distinguish whether you have a bursitis, a tendonitis, a tear, or a frozen shoulder.
Exactly.
Or there are a number of other causes. I mean, I don't want to go into all of them at this point.
We'll go into them a little bit later on.
But, to distinguish what the problem is,
right,
and whether it is what we call an acute problem, which has happened immediately,
or is it late?
Or whether this is something long-standing.
All right.
Or indeed, sometimes it is something that's been long-standing, and then all of a sudden you do something extra.
All right. So let's go through the phone you described with the bursitis and the tears and the tendonitis. How would you treat those patients? Do you have to do X-ray? Do they need MRI? What sort of investigation do they need? Or is any investigation necessary at all?
So
I know I'm pulling you.
No, not at all. And the mainstay is an examination.
Yeah.
The investigations of choice in my practice, I will often do an X-ray.
Yes.
And the purpose of that is actually not so much to diagnose, but just to be sure that there are not other problems related here.
Yeah.
So quite often the X-ray would actually appear normal in a shoulder.
But it's of value because
it rules out anything more sinister or different as the case may be. Ultrasound can be useful as well, but X-rays are so much more widely available. We more often would use an X-ray.
Okay.
And for most of my patients, I would initiate treatment based on talking to them and examining and plain X-ray.
Right.
Depending if we have persistent problems or severe problems or problems that I feel might need a surgical solution, then we will move on to an MRI in that case.
All right. And what is the non-surgical treatments for the patient with this pain, other than the NSAIDs?
So if we pop up slide 9, please.
Yeah.
So patient with some shoulder pain there.
Right.
So the treatment really is rest, ice, as we mentioned. Physiotherapy is a very important part of treatment for these patients with shoulder problems.
Mm-hmm. And then you rule out some of those conditions there as well, is it?
Yes. And so these conditions, diabetes, rheumatoid, gout, and vitamin D deficiency, often are coincident or can overlap with shoulder problems.
All right.
So especially diabetes, and if it's out of control, we see a lot of shoulder problems for some reason.
Okay.
And it doesn't sound very scientific, but we talk about the sugars crystallizing and causing problems in the body, and we shouldn't take that literally, but there is some truth that if your sugars are high, you're going to have metabolic and electrolyte problems.
And then I suppose as well with high sugars, you get this, you get proximal muscle weakness as well.
You do.
And once you have weakness in those muscles over those joints, you probably tend to put more strain on the joints and therefore cause more injuries as well.
Indeed.
Is a possibility. So, Trevor, if you could just go back, the big thing patients want to know is what's the different treatment options, non-surgical treatment options. So you told us physiotherapy, you have injections. What type of injections do you use, and where? Tell us about this injection into the shoulder.
So thankfully, let me let the viewers relax a little bit. Most of my patients actually don't need surgery.
Okay, good.
So we're off to a good start.
Yeah.
But I would say that many of my patients need injections.
Yeah.
And those who watched last week, we talked about 3 different types of injections. The steroid injections, the blood injections, and the cartilage building injections.
Yeah, and those are the same for the shoulder as well?
Indeed, but the shoulder is somewhat different in that by a very large margin, the steroid injection is the workhorse for treatment of the shoulder.
Okay.
we occasionally use the blood injections,
Okay.
and very seldomly would use the cartilage building injection.
Right, and these are mostly for the bursitis and the tendonitis.
That's right. So what I've
Okay.
found over the time that I've practiced
Yeah.
is the patients who do the best,
Yeah.
one, they have to be motivated,
Yes.
but we do a sort of triple therapy in a way. So we do the NSAIDs or the anti-inflammatory medication, we do the physiotherapy, and we do these injections to the shoulder. So we're approaching it from internally by the medication, we're approaching it from the shoulder itself by the steroids. And then the therapy in terms of rehabilitating the musculature. As we said earlier, the complexity of that musculature and tendons is quite complex, and the therapists really help us out a lot with that.
All right. If you tell a patient they need an injection of a steroid into their shoulder, the first thing they want to know is how this injection going to cause many problems? Is it going to be painful? Is it going to cause, do I need a neck? How much shots do I need? These are typical questions your patients at home who are watching this program are going to be asking themselves. So if you could tell us.
Yeah.
I see you have a slide up there.
Probably not that one. That would be the
Oh, that's the injection one from last week?
from last week.
Right,
All
it's the same
But that's all right.
exact chemicals
Yes.
anyway.
So injections to the shoulder or injections to anywhere, we'll just talk about the steroids really. We'll stay
Yeah.
away from the others today.
Yeah,
So yes, it's a steroid.
yes.
For the most part, the steroid remains within the shoulder or whichever joint you're injecting. There is some systemic spillover, but it's not going to cause you to get fat or interfere with your metabolism.
Okay, because it's localized.
It's localized.
It's important for the viewers to understand that.
In diabetics, though, we do see a little surge in the sugars.
Right.
So in those patients, we
They
warn
monitor
them they may go up a little bit.
Yeah,
But generally speaking, the steroids aren't going to be systemically absorbed to a large extent,
Yeah.
and are not going to cause problems with your hormone system at all.
right,
So very localized.
right.
In terms of where we put the injections or how many injections, it varies. When you say get an injection to your shoulder, sure. But at least from my point of view, I will inject a shoulder depending on what I feel the diagnosis is. So sometimes you might get the injection near the back of the shoulder, sometimes over the top or at the front.
Okay,
And that really depends on the diagnosis.
Right.
Most of my patients, you'll either get 1 or 2 injections depending on the
same time
diagnosis.
or over?
At the same time.
okay. And is it painful?
So I'll give you the answer I always give. All injections are painful,
Yeah,
but I use a standard size needle. It's a needle that we would take blood with.
yeah,
So it's no bigger, no smaller than that.
yeah.
And the location for the injection, some locations are more painful than others.
Right,
And most shoulder injections aren't too bad.
okay.
They're not too bad.
And what's the success rate of the injection? Is that something we could quantify? Can we? Is there any studies that tell us how
I think
successful
we
it
can.
is?
There are a lot of studies out there talking
Yeah.
about the use of steroids.
Yeah,
And they're quite variable in terms of what they will say.
yeah.
They will talk about sort of 65% success
Okay,
using steroids for various conditions. In my practice, I actually find it's even higher than that.
all right. So
And
that's it short plus the physiotherapy plus.
that's
the
correct.
exercise.
I would say 85% success rate.
Yeah.
And that doesn't mean you're 100%. Some patients are 100% better,
Yeah.
but others are so much better that they feel confident to go about their daily activities
Over what
and to
time
get on
frame?
with things. Also an interesting question. And
We have to ask interesting ones.
the more you practice, the more you see your patients back.
Yeah.
But I would say for shoulder patients, I will thankfully see them back so they don't desert me. So I must have done something okay.
Yeah.
But often not for the shoulder right back.
Okay.
So I would say about 60-70% actually treated and
they feel better.
and better.
Right. So they feel better like 2 days after, 3 days after, 3 weeks after.
Gosh, another excellent question. Because one of the big problems with steroids is that some patients get what we call a steroid flare.
Yeah.
And when they get this flare, you actually get more pain rather than less.
Overnight.
And for a night, maybe 2 days, 3 days,
Yeah.
you get this flare where the pain goes much more significantly higher than it was before. And thankfully, if we tell people and they understand, it seems to be okay. You know, they take their extra tablets and so forth in the meantime. But once the flare is finished, then yes, the pain starts to subside.
Okay.
And sort of within 2 weeks or so, you
They're
start
back.
to realize that, oh wait, this seems to be working.
All right, good. So, so about 2 weeks time to feel better. So, Trevor, now is a good time for us to take a little break. 2 weeks have passed, the patient feeling better, right? So when we come back, we're going to discuss a little bit more about the rotator cuff injuries, all right? So guys, we're here with Dr. Trevor Seepaul, orthopedic surgeon. We're talking about shoulder pain, and I would like to formally invite you at this time to send in any of your questions or comments to Dr. Seepaul or Orthopedics. All right, so we'll be back in one moment.
You're watching ACTN, The Voice. Connect with ACTN The Voice on Facebook or Instagram at ACTN The Voice.
ACTN The Voice, your family-friendly station.
Keep the popcorn popping, no, we're not stopping. Relax. So you know we in session. Time to talk through it, I don't miss a load. Relax. So you know we in session. Don't you deal it, catch me by your TV. Every Thursday, ACT and The Voice in session. Yo, my name is Elisha. And my name is J Prince. This Thursday and every Thursday at 8 p.m. we are in session.
All right, guys, welcome back. Your health, your choice. I'm Dr. Roopnarine, and we are here with Dr. Trevor Seepaul, orthopedic surgeon, and we're talking about shoulder injuries. So Trevor, just before we went to break there, we did the frozen shoulder, the tendonitis, the bursitis. You were giving us the treatments, you told us about the steroid shot. I kind of went into details about the steroid shot, and it's generally about 2 weeks after they start to feel better, right? So if you could just take us through the rotator cuff injuries,
Sure.
right? That's a big complaint in general practice. So I think you see it more amongst the younger people as well. Athletes and stuff get it as well.
Across the spectrum,
I suppose,
actually.
yeah. So tell us, what is a rotator cuff injury? How does it present, and how do we treat it?
Slide 7 back again, please. So we were talking about the bursitis and the tears and so forth.
Yeah.
And really, these are a continuum or a spectrum.
Yeah.
And because of the tightness of the shoulder that we mentioned, and
Yeah.
the fact that the mechanism lies under the bones,
Yeah.
you can get impingement because when it impinges or it bumps, then you get a bursitis. If it bumps even more, you can get a tendonitis or inflammation.
Right.
If it bumps and it hits harshly,
Yeah.
then you can get a tear.
Right.
And when you get these tears, they
And
can be,
what is tearing there? Muscle or tendon?
it's tendon,
Okay.
or it can be at where the muscle and tendon join together.
Okay.
You can get these tears.
Right.
And these tears can be very minor,
Yeah.
like for example, the fraying of a few threads on a rope,
Yeah.
or they can be more major where the rope is actually completely cut,
Yeah.
or it could be even more major than that where the rope is cut and it springs away so far
Right.
that there is no continuity, or is nowhere near itself.
Right.
And these tears will manifest in different ways depending on how big the tear is
Yeah.
and where the tear is.
Yeah.
Now, that assessment would really determine the treatment, because for minor tears in low demand people, the shoulder can compensate. So physiotherapy will actually allow you to compensate and
What
be
do you
able
mean
to
the
use
shoulder will compensate? The muscles of the shoulder?
The other muscles, correct.
Right.
So the other muscles will take up the slack, if you would say, for
Right.
the torn one.
Right. The muscles are what? The deltoid?
The rotator cuff muscles,
which are the
deltoid, the supraspinatus, infraspinatus.
I sound like a teacher test too. No, but I just want the patients at home to know the deltoid, the big
The
muscle
deltoid
bulk.
one, yes.
So, about our athletes, and when they say they get rotator cuff injuries, right? Is that the muscles of the big muscles of the shoulder getting injured, or is that the tendon inside the shoulder that's injured?
The tendon inside.
Tendon
so
inside.
the deltoid is very rarely injured.
Right,
It's
that's
really
why I wanted to get to that
Really the
question.
ones inside that.
Because
that
you always
cause
say
the
in
problem.
cricket about the bowlers getting injured and damaging
Yes.
the
Yes.
rotator cuff.
Indeed.
Right.
Indeed.
So that's what happens there.
That's what happens. So they get tears there. And if the demand is high, so in athletes especially,
Yeah.
you would want to try to repair those rotator cuffs.
Okay.
Now, in the simplest of ones, the PRP or the platelet-enriched plasma is something that has a role in repairing or healing the tear.
Right.
But once you have a decent-sized tear, it really is going to be a surgical solution for that patient.
All right. So, I mean, question out of left field again. Is rotator cuff injuries the most common type of shoulder injuries you see in cricketers, and the bowlers, and the batsmen, and the fielders?
No, actually.
Right. What is the most common type of shoulder injuries you see in these
The
athletes?
most common thing you would see is a variation on the theme in terms of a dislocated shoulder.
Okay.
So the shoulder actually attempts to dislocate when they throw their arm
Okay.
into these awkward positions or
Right.
high velocity positions.
Right.
And it's that attempt to dislocate causes some instability
Okay,
and
so
some
it's-
damage to the suction cup
Okay.
that we were talking
All
about.
right. So in terms of the rotator cuff again, I know I'm pulling you back into it.
Sure.
So what do we do for those patients?
So the lower demand ones, we can treat them as bursitis and simple tears.
In the same way that we did previously?
as we did previously.
Yeah, as we showed you.
The sort of medium demand ones,
Mm-hmm.
prolonged physiotherapy if they're not keen on surgery,
Mm-hmm.
modification of lifestyle and how you use your shoulder.
Mm-hmm.
But the bigger tears and in the higher demand patients, where these tears aren't going to repair themselves,
Mm-hmm.
and they will feel the deficiency. They will be unable, they will feel weak in the shoulder.
Right. And,
And,
they would have any limitation of movement or anything like that, other than pain?
They tend to have trick movements, so they
What is
tend to
that?
find their way up
Yeah.
to what they need to do.
Yeah.
But it's when they need the strength that it's
They don't
really
have
not
it.
there. It's really not there to do anything more.
Okay. And what's the surgical treatment for those particular patients who have it pretty severe?
So we do a rotator cuff repair.
That's what it's called.
So the rotator cuff has effectively torn itself off the bone. The tendon
Yeah.
is torn off the bone.
Yeah.
So we can actually go in and place it back upon the bone.
Okay.
And we have special stitches and special anchors that we use to do that.
Right.
And that can be done either by an open means, as in traditional open surgery,
Yeah.
or the keyhole arthroscopic means, where we
Okay.
use the cameras in order to facilitate the reattachment.
Is that a common surgery here in Trinidad?
It's not that common. It's not that common.
Do you have any figures, like how many of those would we do a year in the hospital? Or that's something that's not kept, the data not kept?
That's something that's not really kept, and the hospital can be a bad measure
Keeping records and
of keeping
statistics.
records and stuff.
Right. All right, but it's available in the public health care system?
It's available. Quite a few of the orthopedic surgeons would offer rotator cuff repair,
Okay.
both publicly and privately.
Okay, so that's our patients to have that information. Right, so they have the rotator cuff repaired either open or obviously through the keyhole surgery. And are they down for a long time after that surgery?
Yes. Yes, so the recovery really and truly is about 6 months from such surgery.
Wow, that's a long time.
So it's not something you're sort of in and out.
Right.
That's not to say you're entirely disabled for that period.
Yeah.
But in terms of resuming your vocation or any sort of sporting upper limb activities,
Yeah.
really and truly you're looking at about 6 months.
Okay, okay. And all right, and those, so that's the rotator cuff injuries. Anything else you wanted to tell us? Any other important information on the rotator cuff injuries that I might be missing there?
I think just to close off the rotator cuff,
Yeah.
I would say that it really depends on your demand levels.
Yeah.
and your levels of pain. So sometimes you can have a huge tear and no pain.
Yeah.
And that's a totally different thing to a smaller tear and a lot of pain.
Yeah.
So the treatment can be dictated by pain levels as well. So, if you have been told you have a rotator cuff tear, if you're having problems, be it either pain or weakness or inability to use the arm.
Or function.
Or function, yes. Both of those would be reasons to consider
Okay.
a surgical solution,
I understand.
having exhausted other
Okay.
therapies and so
So
forth.
pain is a indication for is a independent predictor of whether somebody should get surgery or not.
Yeah.
Yeah.
Coincidence.
Coincident.
Yeah.
All right. So that's the rotator cuff injuries. So tell us about the horrible one that we see sometimes when we're watching football on TV and so on, and that's shoulder dislocations.
Right.
And we sometimes see the coach running up to the footballer and sticking his hand in and pulling on
And
something.
pulling back the
and
shoulder
pulling
in
back. At least a
place.
long time you would see that, right? And every good football coach knows how to do it. And
Of course.
so tell us about shoulder dislocations. Young footballers tend to get those as well.
Young footballers, slide 5, please. So it's typically some sort of high energy fall on what we call the outstretched hand. So they sort of hand out in front of you or caught in front of you. And it comes back to what we were saying about the shoulder is intrinsically quite an unstable joint, the way it's designed.
This one here?
This one here, yeah. So the small miniature picture is normal, and the one to the right has shown that the shoulder has come out of the socket.
Right.
And it is sitting down just below the socket on this occasion.
That's good there, Josh. Yeah.
And what happens on these occasions is that there will almost always be some sort of damage to the suction cup.
Right.
And as we know, if we have a suction cup on our fridge and somebody cuts out piece or
Yeah.
it becomes a bit older,
Yeah.
the suction cup will fall off the fridge.
Yes. Yeah.
And in a similar situation, if you damage the suction cup for the shoulder,
Yeah.
even though you will put the shoulder back in place, whether the coach would or
Yeah.
a doctor would put the shoulder back in place,
Yeah.
that damage to the suction cup can lead to a long-standing instability.
Right.
So especially in the younger patients,
Yeah.
because of the high energy of these falls,
But actually, I mean, do you recommend that coach puts it back in, or should they go straight to the hospital without coach putting it back in? Or is that sort of outdated nowadays and we don't want coach to put it back in?
it's actually much easier to put it in as soon as it happens.
Okay.
So if coach indeed has some paramedical knowledge,
Yeah.
then it's entirely reasonable.
Okay.
Or if there's a sports
Because it's
doctor
easier to do it right away.
That's right. If there's
Well, I
a
mean,
sports doctor available.
most football games and stuff nowadays, that person's trained. Maybe it's something we need to be teaching as part of first aid as well.
We could do. It's not an easily learned skill,
Okay.
So I suspect it's a dying skill in a way.
All right, so it's best to carry them to the hospital.
If in any doubt, yes, don't try to put it back
All right.
in.
So our young 16-year-old or 17-year-old is a typical age group,
Or even a bit older,
right? Fall down in the park with outstretched hand.
yeah,
kick comes
20s up to 25,
All right. So this guy ends up in the hospital, and the accident and emergency doctor, sort of manipulates the hand and puts the bone back into place.
Yes.
What happens there and thereafter? Is this going to be a problem going forward? I know you mentioned the suction cup sort of gets injured. Would our young person have damage to that suction cup, and would he always have problems, or would he not always have problems? What happens next?
So once the shoulder's back in, the doctors will x-ray it, they will make sure it's in, they will put you in a sling, and you'll probably go home.
And be happy.
And you'll come back and see your orthopedic doctor in a week or so. And we will arrange physiotherapy and stuff, which will be important. But what actually happens long term, in a patient, for example, age 25, that patient actually has an 85% chance of having some degree of instability of the shoulder.
Right.
Now that instability could be minor, where they sort of get a catch or a pain in a certain position,
Yeah.
or it could be major by where the shoulder keeps falling out of the socket,
Right.
even without being prompted, having fallen over, it could just decide to pop out.
Right.
Because the suction cup is so badly damaged
Right.
that the shoulder just pops out.
Okay. And what's the options for these patients?
So if you get slide number 6, So the interesting thing about shoulder dislocation and shoulder instability, there are really only two treatments.
Yeah, look the slides up there.
And those are the two treatments.
Rehab,
physiotherapy, rehab, and surgery.
Okay. And a combination of the two.
And a combination of the two, yes.
Right. So tell us what do you do in that surgery? So what is being done there?
This particular surgery that's shown here, it can be done in an open fashion or once again with the arthroscopic or keyhole. So this one is the keyhole surgery.
Right.
And the gold standard now has actually shifted from being open to keyhole.
Okay.
Because they do so much better with the keyhole surgery.
Right. In terms of healing time and so on.
Healing time, and remember when we do surgery, we intrinsically do some damage as well.
Yes, of course.
So the fact that you can get into the shoulder without cutting anything is actually very conducive to a better recovery for these patients.
Right. So what does the surgeon do there to help this patient in the theater?
So when we go in, we would have had an MRI first of all, and we would set our target upon the suction cup or the area of the suction cup that is damaged.
Yeah.
And what happens, and for the purpose of explanation, that area of the suction cup is sort of furled backwards on itself.
Right.
And what we need to do is free it up and stitch it back down so that the rim of the suction cup is
okay. So it's all about
again.
Focusing on the suction cup.
Indeed.
All right. So Trevor, now's another good time to take another break. All right. So guys, we're going to take a 1-minute break and then we'll be back.
ACTN The Voice welcomes you to join us for our newest agricultural television series, Harvest.
Welcome to Harvest. We're doing it double again, north and south. This morning we start here in Brazil Village on Bethany Estate with Michael and Jacinta Mill.
You can look forward to a personalized tour around scenic Trinidad and Tobago, showcasing different agricultural practices and teaching us self-sustenance.
So Wendy, you're about to show me your bromeliad house.
Yes.
Oh, this is lovely.
This is what our customers refer to as the Mecca for bromeliads.
Explore the many ways to make your harvest right for you.
So our chicken coop is more or less built at a height whereby it's easy for us to go and just remove the wood shavings into our barrow.
Now, you don't plant out your seedlings, you buy the seedlings, right?
Yes, we purchase our seedlings.
Here we are on a not quite monocrop site, but we have rows of tomatoes, rows of sweet peppers, and then you have the Milnes polyculturing.
Join us every Tuesday at 6:30 p.m. Harvest, a new dimension in agriculture. ACTN The Voice launches a new and versatile culinary series called Stacy's Kitchen.
Hi everyone, welcome to Stacy's Kitchen. And on today's episode of Stacy's Kitchen, we will be cooking up a Thanksgiving feast. Our rolls are ready and looking yummy. Nothing like a good curry chicken and some basmati rice. So I'm gonna start putting my wings in to fry.
We will showcase how to make tasty international cuisine with our local products. We emphasize meals on a budget with our selected ingredients.
Restez à l'écoute, Stacy's Cuisine. Au revoir.
So you can put how much, depends on how big you want it. So our fish is ready. Oh my God, look at that. Oh my God, oh my God. Just like paratha, this is lovely.
Join us on ACTN on Monday evenings at 6:30 p.m. Don't miss Stacy's Kitchen, exclusively on ACTN The Voice.
Guys, welcome back. Your health, your choice. I am Dr. Roopnarine. We are here with Dr. Trevor Seepaul. So, Doc, we went through most of the shoulder injuries there, right? Before we go into the osteoporosis, I think Joshua is telling us we have some questions coming in. Josh? Yeah.
Wonderful.
Yeah, if you could start with the first question, let's get some viewer feedback. All right. Can you address the emergence of Baker cyst, why it happens, how to treat it? I think we touched on that last week.
We did touch on it a little bit.
Yeah. You could just repeat it.
Yeah, sure. Baker cysts are really a reflection of another problem. and it means that something is not quite right in the knee.
Yeah.
And that could be arthritis,
Yeah.
or it could be a tear of the cartilage or menisci within the knee.
Yeah.
And then what happens is, like any injury, we get a swelling, a buildup of fluid.
Yeah.
And sometimes that fluid can pocket or seclude itself at the back of the knee.
Yeah.
And that is when we have a Baker's cyst.
All right, so Josh will answer any unanswered questions from last week and any new questions coming in this week as well, once it's on orthopedics. So you can put up the next question now, please. Yeah, no problem. So Doc, if he's just taking this, fixing up there, tell us about osteoporosis. What is osteoporosis?
All right, so osteoporosis in the simplest terms is brittle bones.
Yeah.
And it is a consequence of aging, but not only aging. As we get older, our bones become a little bit softer, they become a bit more brittle,
right.
But there are a number of other factors.
Right.
We could put up slide 10, I guess.
Yeah, and then we'll go back to the question.
Typically, a bone will have a sort of honeycomb appearance.
Yeah.
Like on the left.
Yeah.
And the one on the right also looks a bit like a honeycomb, but you could see that the honeycomb is a little bit more spaced out.
Right.
And that's really what osteoporosis is, where the architecture of the bone
Yeah.
becomes so spread out
Yeah.
that it is unable to hold the weight or structure as it would have when it had a proper sort of honeycombed.
Right.
And these patients can present with bone pain, they can present with fractures.
Right.
Typically those fractures or breaks of the
At
spine.
least the bone pain. All right. So Josh, you could go back to the viewer feedback there, please. Right. Good. Good night. What is the time frame for a minor clavicle fracture to heal? And can it be treated at home? That's a good question, Doc. We didn't discuss clavicle fractures.
We didn't discuss fractures at all.
Yeah.
But sure.
It's a common
So
enough.
clavicle fractures, quite common. The healing time varies from children
If you could just
to
tell
adults.
the other viewers, where is the clavicle?
So the clavicle or the collarbone sort of starts just near the center of the chest and ends nearly by the tip of the shoulder.
Right, so it's a long, fairly
and
long.
it's sort of near the skin. You could sort of feel it underneath
I think I know it there. That's a collarbone, really.
So the collarbone is quite commonly fractured, more so in children than in adults, but we do see it quite often in adults as well, and especially high energy injuries, motorcycles, motor vehicle accidents, etc. And a typical clavicle will take about 6 weeks to heal.
6 weeks.
Okay. And sometimes a bit longer, 8 weeks or so, but the actual rehabilitation can take about 3 months, because then the muscles and everything have to build back up and you have to start back using the shoulder.
And they're in a sling for that full time? Or?
They're in a sling for the first 4 to 6 weeks.
Okay.
And then as they start to feel more comfortable, the sling can be taken
So it's
off.
very rare that you'll need to do a surgical treatment for that, is it?
Well, I was thinking about that as you said it, and really and truly, the clavicle, we've started operating on it more and more. And basically, just to keep it as simple as possible, if the ends of the bone are together, or somewhere close by together, or a little bit of an angle, the bone will heal.
Yeah.
If, however, there's somewhere like this,
you have to do something.
We have to do something else.
All right, Josh. Any other viewer feedback? Do you recommend acupuncture for orthopedic pain? Good question. Complementary medicine, doctor.
I am a big fan of acupuncture, actually.
Okay.
And it's something that is limited in Trinidad in terms of being offered.
I would say as well to that viewer that put that up, it's something to us in medicine as well. Sometimes we don't go through those alternative or complementary treatments enough with the patients as well. And I'm glad you brought that up, because as well as me myself as a host of this show, sometimes I need to ask a little bit more about complementary and associated medicines that we could use to help the patients. So acupuncture is something that you would recommend for your orthopedic patients?
I definitely do.
Is it proven? Is it scientifically proven to help?
I don't think it's scientifically proven to help.
Yeah.
But I would work with my patients to find any cure other than surgery.
Yeah. Okay.
And if or when we are going for surgery, we need to be confident that we've done everything we can.
Yeah. And what is the purpose of the acupuncture? Is it just to help pain, or?
So
I know that you're not an expert in acupuncture, but
it relies on certain pathways that have been established.
But you're a
in the
proponent
body.
of it, so you should be able to answer the question.
So it relies on certain pathways that the pain pathways within the body.
Yeah.
And the use of the acupuncture is supposed to reduce the activity of the pathway.
Okay.
And reduce the response
to
injury.
Right.
So the injury would still be there, but the body would not respond as actively or as exuberantly or excitedly.
And it can help with pain as well.
That's right.
All right. So Josh, any more feedback from the viewing audience? Should someone with arthritis continue leg workout at the gym? And should one keep the workout light, or can I go heavy? It's odd because we don't really know the demographics of the patient.
Right.
We don't. It could be grandpa going heavy, or it could be a young person. But can you answer that question?
Generally speaking, if you have arthritis, you're going to have to take it a bit lighter.
Yeah.
You know, and obviously it depends on the amount of arthritis and the amount of pain.
Yeah.
But that said, I would much prefer that the public out there and my patients at large do some exercise.
Of course.
And whether that's, you know, a light workout in the gym, whether that's a treadmill or walking along the streets or in a savanna, you know, you do what your body is capable of. There's no point you stress yourself out doing a heavy amount of exercise and then you're complaining for the next 3 days that you're in pain.
Yeah. So correct me if I'm wrong, Trevor, but we kind of mentioned this in the last program, right? The purpose of people going into the gym to exercise with for example, knee injuries or and maybe even arthritis in the knee and so on, the purpose is not really to exercise your knee or to work out your knee. The purpose is to build up the muscles around the joint to support the joint better so that it improves stability and you improve strength, because once a joint is diseased or has a problem, the muscles is what provides the functionality and the stability. And the purpose behind all these exercises, a lot of the exercises and a lot of the workouts is to improve your thigh muscles and your calves. Am I correct there?
Indeed. I mean, muscle strength is key, and range of movement.
And range of movement, flexibility as well.
So things like yoga as well, you know, it doesn't have to be a weights workout.
Yeah.
Many people prefer yoga, Pilates, swimming even, you know.
So it does not necessarily have to be a light workout, depending, it's just what the patient could tolerate.
Yes, I mean, you're not really going to damage yourself.
Yeah, because you're working out your muscles, not your joint. All right, so you have any other questions there for us there, Josh? What can be done about stenosis in back apart? What can be done about stenosis in back and spine, I suppose, apart from surgery?
A little bit off topic, but sure.
Yeah, it's orthopedic.
So, yes.
We said any orthopedic question, though.
So, canal stenosis. Canal stenosis or spinal canal stenosis is really a disease of the older populace.
Yeah.
And it is really that the bone is so narrowed around the nerves now that you get pain going down the legs, and it can lead to weakness as well and limited walking distance.
Those patients seen by orthopedic or neurosurgeons?
Bit of both.
Okay.
Bit of both. And surgery is definitely an option. The other options really are some of the simpler things. Weight loss, just from a point of view that if you're carrying less weight and your posture improves, your spine will have a better posture and you won't be putting as much load and squeezing the nerves. Physiotherapy can help with posture-related things. And light exercises as well is important, keeping yourself relatively active. But I think perhaps what the person is asking is what your doctor can do for you. I mean, the medications, such as the anti-inflammatories, can be of some use. And we do what is called a chordal epidural sometimes, which is an injection of steroids into the base of the spine. And what that can do is ease the swelling and inflammation around the nerves, and it can give you temporary relief. And sometimes the way I look at it, it gives you a reprieve to allow you to do those other things, which is lose a bit of weight, exercise, control your posture. So hopefully I've answered your question there.
You have answered the question, Doc. But I think it's also important too that sometimes a decision is made that surgery is necessary. And obviously I always I don't want people to, because of looking for an alternative when surgery is the treatment, sometimes we could cause harm to ourselves by not going for what is the best treatment or what is the recommended treatment based on fear. Do you understand what I'm coming at?
I think that's a very, very important statement, and those who have listened to me will probably realize that I don't rush to surgery, but nevertheless, you know, if you step into my office and I say, look, sir, ma'am, you should have some surgery. Then it's said, hopefully with a medical background and a good heart, but you should go and have certain people that yes,
you have to have
surgery, or it is highly recommended. One cannot force people, but it's highly recommended.
So we don't know the circumstances of that particular patient, but you can also go back to a doctor and discuss it.
Indeed.
All right, Josh, so you have, I think we have about 2 more questions there. Good night. I'm 40. I do have a lot of muscle pain, especially in my neck. My doctor told me I'm underweight. What is your input? Thank you. My weight is 100 pounds. I do have a lot of pain in the neck, basically, is what they say. And the doctor said that she's underweight.
Right. So that's interesting. And just working with the information you've given me, one is what we call cervical spondylosis or arthritis of the neck. You sound a bit young for it. Possibilities, rheumatoid arthritis would be a consideration. And as you mentioned as well, vitamin D deficiency can also be a significant problem. You didn't mention whether you had an injury or anything before, so that could have some impact on the situation. But I would say it's a little bit unusual for a 40-year-old to have a significant neck pain and neck pain only.
It needs to be investigated.
So it needs to be addressed and investigated.
And something that probably need a little bit more investigation and closer medical management. I think it's not something we could easily address
on the television.
On the spot, Josh, how long does a fractured clavicle take to heal? Okay, we kind of mentioned, but Kamal probably know.
6 weeks for the most part. 6 to 8 weeks.
All right, cool. Josh, any more questions there before we go back to the osteoporosis? All right. So, Doc, osteoporosis, that showed us there weakening of the bones. What are the risk factors for osteoporosis? Who's going to get this problem?
Slide 11, please.
Who
and how?
And how.
So females are more prone to developing osteoporosis, and that's to do with the female hormones, or rather the absence of those female hormones after the menopause, when the hormonal changes occur. The elderly as well, because bones do naturally deteriorate with age, and also you're less physically active, so your bones need to be active. They need to have a certain amount of stress to maintain their strength. Race is an interesting factor, and you know, many of our books are written in the first world, and they talk about Caucasians. But interestingly enough, in Indian populations, and indeed in Trinidad, we actually see quite a lot of osteoporosis.
In East India?
Indeed. And small frame people tend to have a worse time with the osteoporosis than patients who are larger framed. So those are really the risk factors.
And how does it present?
So
how would somebody know they have osteoporosis?
Most people wouldn't have a clue. So it's really a sort of silent disorder that creeps up on you. But you can present with bone pain. You can present with fractures or breaks, back pain. Women may have a sort of, especially women, I'm not picking on women, but it affects women more so, will have a hunched over posture as they get older.
It affects smokers as well more.
It affects smokers, yes.
And so they might not have any symptoms, but they develop hunched over. They might present with fractures, might present with bone pain.
So it's quite a diffuse spectrum, and I think women over 65 for sure should consider whether or not they have risk factors for osteoporosis, and possibly do some investigations to find out.
And what are the investigations?
Could we see slide 12? Sorry, not 12, my mistake. Slide 13.
And we have about...
So the investigations really, the chief one is a bone density test. And many of my patients ask me, well, Doc, how bad is it to take that test? Because some of us are scared of MRIs, they have been enclosed in the tube and whatnot. Thankfully, the bone density is as simple as having an X-ray done. So it's a quite user-friendly and patient-friendly test. And it will give us information about whether you have osteoporosis and the degree of osteoporosis. In addition to that, we tend to check blood tests. So we look at calcium levels, vitamin D levels. Sometimes we look at hormone levels, just to be sure that these are adequate, and to be sure that there are no other problems that could be related to or causing the low bone density.
And the treatment, right?
So once we've established that the bone density is poor,
Yeah.
there are treatments, and these treatments can be of oral or IV. And from the oral point of view, the tablets can be taken either weekly or monthly. From the IV point of view, either 3 monthly or on a yearly basis.
Right.
And these must always be supported with adequate intakes of calcium and vitamin D.
Right. What's the actual medication that they're taking?
So the chief, there are many on the market, but by a long stretch, something called the bisphosphonates are the most common. And we have alendronate and Fosamax and Bonviva. These are things that people may have heard about before.
Right. So, I mean, it was important for us to kind of talk about osteoporosis because that would help the patients, help prevent patients from sometimes ending up under your care.
Most definitely.
Yeah.
Most
So,
definitely.
Trevor, we've come to the end.
Oh. Time flies, really.
Yeah, it has. It has. It's been really, really good. You gave us a really enjoyable 2-part mini-series on orthopedics. There was a lot of engagement from the audience. People enjoyed it, and I would just like to thank you for that.
Yeah. Thank you very much for having me. I have enjoyed it thoroughly on both occasions.
I'm glad.
I am sad that you're not having me back, but I'm sure...
You're always welcome back.
I'm sure that we need to move on and let our audience hear about all the other wonderful things that are available in Trinidad and Tobago and what medicine can do for them.
Exactly, exactly. All right, guys. So that's Trevor's contact details there. I know some of you were asking earlier. It's Gulfview Medical Center. All right, guys. So again, thank you to Dr. Trevor Seepaul. Thanks to Josh for producing the show. Thanks to all of you at home for tuning in. Thanks to all you guys who sent in messages. Have a pleasant evening, everyone. God bless. And we will see you again next week. Take care, everyone. Have a pleasant evening.